Hello and welcome to a Health Podyssey. I'm your host, Alan Weil. New prescription weight loss drugs like Wegovy have proven to be highly effective, but they are also quite expensive, making insurers reluctant to cover them except in limited circumstances. Medicare faces this precise challenge. It's statutorily prohibited from covering drugs for the sole purpose of weight loss, so Medicare coverage of these new medications remains restricted. But what would happen if those restrictions were lifted? That's the topic of today's episode of A Health Podyssey. I'm here with Benedic Ippolito, Senior Fellow in Economic Policy Studies at the American Enterprise Institute, and I should note a member of the editorial board of Health Affairs Scholar. Ippolito and co-author Joseph Levy published a paper in the September 2024 issue of Health Affairs that looked at how broader Medicare coverage of anti-obesity medicines would affect program spending. The figures, not surprisingly, are quite large. We'll discuss those in the show today. Dr. Ippolito, welcome to the program.
Thanks very much for having me.
So this is a great topic. It's certainly on people's minds. Let's just start sort of with the policy context, if we could. What is the current Medicare coverage status for these blockbuster medications?
Yeah, it's sort of a simple question with an annoying answer, where it's both they're covered and they're not covered. And one of the things you have to understand about this world is we talk about these drugs as weight loss drugs. And I think that's kind of the thing that drives national attention, but they are not just weight loss drugs. And that is sort of going to become a big issue moving forward. But for right now, you can basically think of them as they're primarily were initially approved for diabetes, and they're quite good at controlling certain diabetic outcomes. But they are also approved for weight loss. And so if you're a Medicare beneficiary who has diabetes, they are covered as far as you're concerned. I mean, we looked into the formularies. Basically, everyone in America has the option of signing up for a plan in Medicare that covers Ozempic, for example. But the nearly identical sister product that's approved for weight loss is a different story. And that's really where all the policy attention is. So if you are somebody who has obesity, for example, in Medicare, but you do not have diabetes, then this prohibition really matters for you. You cannot get access to these products. And so that's millions of people, and it's obviously the reason why people care about this policy decision.
So I love that you started us off on the right foot. You're right. I mean, in the popular culture, these are about weight loss. And that is, as you said, I won't try to repeat it, that is really only part of the story. But it is a part of the story that makes this complicated. And of course, there's a high correlation between weight and any of a number of diseases. We'll come back to that. Well, so given what you just explained, if we're trying to understand what broader coverage in Medicare would look like, what would that be? Is it just a lifting of the prohibition? Is it an expansion of the conditions? I mean, what would it mean for Medicare to say, we're going to do more of this?
Yeah, so literally the policy change would be that you lift the prohibition. You essentially allow insurers to cover this, and essentially the federal government is willing to pay for it, right? That's the key lever. In terms of what would that mean? There's two things. First, I think it's useful to characterize how many people are we talking about here? And there are some caveats that I'll come back to, but we kind of went through this little cascading exercise where, there's about 50 million Medicare beneficiaries who have drug coverage. And so this is sort of the universe of people who might plausibly be affected by this policy change. About 18 million of those people could hypothetically qualify based on their BMI or their body mass, essentially, for a drug that treats obesity. Among those people you talked about, there's a lot of co-occurrence of conditions. About 40% of those people have diabetes in Medicare, so they already have access to something like Ozempic. So that leaves something like 11 million people in Medicare who have drug coverage, who would otherwise qualify for one of these products, who currently cannot get access to the product. Now, that number moving forward may change. And I think this is one thing to keep in mind. We're kind of taking the easy route here. We're forecasting the short term. The long term, lots of things could change. If these drugs become available, maybe somebody goes to the doctor and gets diagnosed as having obesity that currently doesn't have that diagnosis, right? So that kind of thing might change things. But I think there's this second question, which is also hard to predict, which is, all right, so insurers are allowed to cover this in Medicare. That doesn't mean that it's going to be trivial to get access to the products. And that's something where we kind of have to just take guesses. But it's very likely that, at a minimum, you would have very strict, what you call prior authorization rules. You have to have the right diagnoses. Your doctor has to sign off on this in order for the insurance to cover it. But that's sort of the second stage that comes after the key policy change, which is allowing these plans to cover and the federal government actually paying for them.
So you foreshadowed most of the topics I hope we'll discuss in the rest of this episode, but we'll go deeper into them as we go forward. I mean, basically what you're saying is that there's this threshold issue, that federal law prohibits coverage for the purpose of weight loss. If you eliminate that barrier, doesn't mean there aren't other barriers. And in fact, there almost certainly will be, because the potential outlays here are tremendous. So let's start with what you said, which is you took sort of the short-term view, because the dynamics we're going to unleash here, if this happens, are quite complex, and different people may differ in what they assume would happen. But let's start with sort of the core short-term picture. You look at people gaining coverage for the drug, using that coverage, the cost of the drugs, and like you put all of those together and they give you some numbers. So let's just sort of start with that base picture.
Yeah. So the way we kind of do this, I won't go through the sort of how the numbers all get combined, but the basic story we tell is what would happen if tomorrow Congress says, all right, we're changing this law and you're allowed to cover these products. We think that coverage would probably be pretty broad. And the reason we say that is because coverage for the diabetes versions of these is basically universal. So we kind of take that first stage as given. We then factor in some things like, well, how many people are going to stay on these products conditional on getting a prescription? The answer to that is a lot less than 100%. And that's not just true of Wegovy and things. That's kind of a universal, I think, underappreciated factor when it comes to drug markets. And then we consider things like how much might this offset other healthcare spending? And we basically, our sort of baseline numbers are that if 10% of the newly eligible people actually went out and got a prescription for something like Wegovy, then the federal government would spend about $6 billion more per year than it does today. And for context, total prescription drug spending in Medicare is on the order of $140 billion. And so, $6 billion is not, enormous, but that is far more than a drop in the bucket, I would say. And just for context, so 10% of newly eligible people means about 1 million people. All right, so that's quite a bit. I think it's sort of interesting to talk to other people about your research, because the things that you focus on, I think, are sometimes not the things that other people focus on. But stuff that
give me an example. I'd love to hear that.
Yeah, so so people really are interested in this concept of cost offsets. So the idea that if you can help reduce obesity, then you're not just going to save money on other healthcare expenditures. Heck, you might even offset the total cost of these things. And I mean, like, people on the street want to talk to, like, that's one of the first things people want to talk about. And that same thing is true of members of Congress. They are fascinated by this idea. And I think that's partially driven by the fact that, these budget scores really play a very important role in whether legislation gets passed. But there's a lot of optimism, I think, that these products could lead to very large healthcare saving. Whether that happens is really an open question. I mean, there's some really interesting work out there that I think methodologically probably isn't the tightest in the world. But if you look at people who had bariatric surgery, it's kind of sobering. There's really not much savings down the road from bariatric surgery compared to kind of plausibly similar people who didn't have that surgery. And so there's this sort of juxtaposition of, on one hand, a lot of optimism, but some evidence that says that maybe these aren't going to be huge offsets. So that's kind of a big open question. The other thing I get a lot of questions about, or where I think people really lightly disagree with our work, is that people tend to be very, very optimistic about how fast utilization of new drugs increases. So, I mean, you'll even see, there's New York Times op-eds where they say, if everyone in America who's obese took these products, here's how much it would cost. Well, there is no drug in the world where everybody who has that condition takes the drug number one. And even if they all got prescribed the drug, adherence to these things is very, very imperfect. And so I think, we think that, 5 or 10% uptake is quite plausible in the short term. That's consistent with a lot of investor projections. But that's one area where a lot of people, I think, read the paper and they say, geez, that seems awfully conservative to me.
Well, those are great topics that I want to spend a little more time on. I mean, certainly the offsets is something we hear all the time about prevention. Everyone says, we should invest in prevention, and we certainly should. But the number of preventive services we have that actually reduce healthcare costs is small. We have some, but this sort of sense of optimism, I totally get. And I have to admit, as an editor, I saw the paper and I saw 5 or 10%. And my first reaction was, well, what about 50%? Right. So I get that sort of.
And maybe one day it will be 50, and down the road, it does. And, you have to think about, I think we're not used to just thinking about the mechanics. Millions of people need to go to the doctor for that. They need to get, just getting the appointment, then getting the script, making sure that you get the diagnoses recorded, making sure you pass the prior authorization with your insurance company. Actually, and this sounds silly, but conditional getting the prescription, even just going to fill the first one, you get a huge drop off. And so, these things, if you're talking short term, are really quite important. If you're talking 15 years down the line, much, much less important. But in the near term, they matter a lot.
Right. And just to be clear, your assumptions here are evidence-based. They are assumptions, but they draw from a literature that we have about things, for example, particularly about how many people fail to fill prescriptions that they have, or as you note, just the throughput of the system. So there's a lot of friction here. And yet, even with all of that friction, 10% will sound like a low take-up rate to many people. But even at that point, it's $6 billion, which, as you say, it's not all of healthcare spending. It's not going to double Medicare spending on drugs, but it's certainly something we would notice.
Right. And, just to be clear, we illustrate these results for sort of a range of uptake estimates. We go as high as 20% because that, to us, again, in the short term, starts to push what we think is realistic, not in the long term, but in the short term. But, we'll talk about it later, but the long-term projections are so tough for this. That's just a whole different can of worms.
Well, I am going to open that can of worms with you. We'll open it after we take a short break. And we're back. I'm speaking with Dr. Benedic Ippolito about what the projected cost to Medicare would be if it expanded coverage of anti-obesity medicines currently restricted by federal law. We've discussed the challenges associated with coming up with even short-term estimates. But as we noted right before the break, it's much more complex to think about the long term. And one dimension, you've already raised various dimensions, uptake of the prescription, whether people would fill it and take it, and some offsets. But there's this whole other dimension we haven't even touched on, and that's the price of the drug. Obviously, if you're estimating the cost to the program, it's volume times price. We can look at the price today, and that's what you can do. But imagine a world where demand for these drugs goes way up. Presumably, that's going to have some not entirely predictable, but somewhat predictable consequences for how the drug is priced. So can you just sort of get our listeners' heads to at least be thinking about the dynamics here the way you would?
So drug pricing in a static environment is, as you know, this unnecessarily complicated concept to explain. In this dynamic situation, it is a total mess. And so the key thing to think about here is that there's basically two products on the market. Novo Nordisk makes they make two nominally different products. They make Ozempic and Wegovy. Those are essentially the same product. One's just a diabetes product, one's an obesity. Fortunately, Eli Lilly also makes two products, Mounjaro and Zepbound, that are approved for the same thing. So the upshot of that is that there are two direct competitors, and I mean really direct competitors. And so that does help a lot on pricing. So right now, these products cost the insurer something like $8,000 a year for the weight loss version. If you are trying to think about spending over the next 5-10 years, particularly in the Medicare program, thinking about what that number is going to be is very, very difficult. So the positive things are, even in the short term, the fact that you have two almost identical products competing against each other means they're trying to fight to get on the insurance plan against each other. That really helps. There are more products in the pipeline coming down the road that could either push prices down, or if something comes down the pike that is just clearly better than what exists, then kind of the market-wide price might go up. The big X factor, though, is that Ozempic and Wegovy are going to be selected next year for Medicare negotiation. That means 2 years thereafter, they're going to have a sort of rate-regulated price. What that price is going to be, I have no idea.
You and the rest of the world want to know.
One of the challenges of this Medicare negotiation process is that it's either it's a good or bad feature. The administration has lots of flexibility about how they set a price. The downside for somebody who's trying to forecast is they have a lot of flexibility to set a price. And so it really creates this challenge. So who knows what the price is going to be in 2 or 3 years. And then not long after, Ozempic and Wegovy are going to have generics come onto market. And so you kind of add that up. And my best guess is that the price for weight loss medications in this class are very, very likely to trend down over time, where the big risk of it going up, and risk is sort of, you could see this as a good or a bad risk, is that something comes on the market that's just fabulously effective compared to what we have. And, that's kind of the big X factor. But my cautious expectation is that the prices are going to continue to go down a little bit.
So that's super helpful. And again, I mean, we can only project out here, but a couple of thoughts come to my mind as I listen to you. I mean, the first is, the traditional economic view would be more demand will drive up price. But as you note, that's occurring in a context of some downward pressure that's probably stronger than that upward pressure.
And it's also, I mean, you have to think about it. It's not just demand, right? So the price that exists in a market is this equilibrium between the supply and demand. So right now, the supply is actually somewhat constrained. And if you think about often the kind of initial demand for products is probably the high willingness to pay people. So it's not actually implausible that the current price is really the sort of particularly high price. And as supply increases and as you get more sort of quote unquote kind of normal, less enthusiastic demand, maybe actually the price goes down a little bit. But I think your overarching point is obviously right, which is there's a lot of things going on. It makes it very hard to predict.
Well, and your point about a new drug, which, again, if you eliminate the prohibition against Medicare covering weight loss drugs, you're not eliminating the prohibition against the two drugs that are currently on the market. You're eliminating it for potential successor drugs. And that sort of, I guess, is maybe a place to turn. We could go on all day and we're going to run out of time here. So let's use that as an opportunity to turn to another topic that I want to make sure we discuss. Your paper sets out the dollars. This is our best estimate. But of course, the language that you described earlier about people assuming it will have offsetting savings associated with weight loss. The dollars aren't the only thing that go into making a decision like this. So when you think about a policymaker deciding whether or not to change the statute that prohibits these drugs, you've given them a number, but what else would you say they should be thinking about?
Yeah, I mean, this is like a issue that comes up constantly working with folks on Capitol Hill. The budget estimate gets a lot of attention, and for good reason. But if you are thinking about this issue of what is worth passing, the question that you should be thinking about is, are we getting benefits, clinical or non-clinical benefits, that are, quote unquote, worth what we're paying. We're giving you a ballpark of what we think the cost of this is. We're not telling you what the benefits are or are not. And there's a whole, estimating that side of the equation is at least as complicated as what we're doing, because you have to think about all sorts of things, right? So, these losing weight improves all sorts of clinical outcomes, which is going to be reflected in future approvals for these products. But, people have less pain. They go to the doctor less for knee pain. They avoid potentially very serious clinical outcomes, heart attacks, things like that. But there's also this other elements, which is, well, if you're in less pain, it's easier to work, or it's easier to enjoy life. And you should value those things. And so the question that a policymaker should be trying to weigh is, what are the benefits of these products? Is it worth, the $6 billion price tag that we're estimating? And we don't have an answer to that question, but this is an input into that decision process.
It makes me think about, again, earlier we were discussing in terms of the offsets, the prevention side of this. It is a commonplace in our policies, whether in healthcare or elsewhere, to sort of, because we want to limit the role of government in various places, we wait until people really, really need it. And that tends to lead to underinvestments in prevention. We could say that about a lot of social policy, and we could debate. I'm not trying to start a big debate about that, but there is this tendency that you don't want to step in too early. That's not the space for government, and so you could see this as, well, we can get all those benefits if we just wait until people have medical conditions, and then, as you note, with diabetes, it is covered. So I don't know. I guess I'm wondering, is this just sort of the traditional prevention debate that we have in so many other places?
Yeah, to some degree, I think so. This is a particularly acute version of it, because I often tell people it's sort of in drug pricing, there's a lot of drugs that get attention because they have a price that just clearly seems to, for whatever reason, outstrip the clinical value of the product. And ironically, that's not really the case here. These are expensive, but they do have a lot of clinical benefits. It's the demand. It's the size of the demand that really sets us apart. And so I do think it's sort of it's a story. It's a version of that prevention story, but kind of on steroids, in the sense that, there's 70 plus million people in the country, or adults in the country, that are obese or overweight. And so that's just enormous in terms of the budgetary consequences. That said, I don't want to get ahead of where you're going, but, you are still kind of waiting until somebody is obese to treat them. And so it's not like, you're kind of getting way ahead of this. I almost think of, one of the things we show in the paper is that these products they're currently approved for diabetes and for weight loss. And there's a new cardiovascular approval for Wegovy, but they're being tested in near-term, large-scale phase 3 trials that are going to be finished in the next couple years. They're being tested for sleep apnea. They're being tested for heart failure, chronic knee pain, knee osteoarthritis. The prevalence of those things among particularly Medicare beneficiaries who would qualify for a weight loss product is very, very high. More than 3/4 of obese Medicare beneficiaries have one of the other conditions. And so in some ways, I think another version of this is it kind of just feels like we're going to get there eventually, where basically everyone's going to have access. It's just going to take these other indications sort of. So I don't want to make my own studies seem sort of like a moot point, but in some sense, if all these other things get approved and covered, well, whether Congress allows coverage for weight loss products or not becomes much less of a big deal.
If everyone has a comorbidity, that's exactly. So interesting. We can't go down this rabbit hole, but your talk about value also suggests the importance of a whole other conversation. It reminds me of the hepatitis C drugs, which were very expensive, but also very effective in curing a disease that takes a terrible toll and that was not really curable through other methods. And the universe there was large, but nothing like this large. And then, of course, you also think about something like Alzheimer's disease, where, in some sense, this is a precursor to the discussions we're going to have if we come up with better treatments.
I don't want to make this even scarier, but these are also being tested for Alzheimer's.
Right. Well, there you go. So, I mean, as you say, it's the number of people, it's the sheer size that just makes the numbers so big. Well, look, we're coming to the end of our time. This has been so interesting, but I have to ask, we're a policy journal. You're an economist. You're not a clinician, and that gives you a certain perspective on this. But let's say Congress holds a hearing on a bill to eliminate the prohibition against Medicare coverage of weight loss drugs, and you're up there testifying, and they say, well, Dr. Ippolito, what should we do? What would you say to them?
My general attitude is that these are the good problems to have. These really effective products that are expensive are the problems that we ought to probably find a way to finance. And, I think any reasonable person would say that as that implies, there are other areas where we're probably not getting, tons of clinical value. And so it strikes me as, the sort of optimal idea here would be to try and expand coverage of these things if you can. And maybe in sort of conjunction with that, try and take a serious look at the areas where Medicare in particular pays for drugs in ways that are probably not really doing a great job of matching prices and values. Things like physician-administered products, particularly oncology, often gets a lot of attention, and we'll go down the rabbit hole. But Medicare doesn't really get lower cost biosimilar uptake quite as fast as it probably could. And so thinking about this in a sort of holistic sense is probably where I would be. Is try and make it work for these really effective products. And maybe the way you do that is trying to refine the way you pay for drugs in general to sort of align prices and value a little bit better.
Well, I have to say, I didn't know how you'd answer the question, but I really like it. And I like the juxtaposition between the hard questions and the easy questions. There are a lot of places that we spend money that we know we're not getting value. And so here we have a situation where, sure, it's a hard decision whether or not to spend this much of taxpayers' money on a medication, but we have lots of reason to think that there's value to come back from it. Whether it's exactly the right amount, that's a question we can debate. But whether it's in the ballpark relative to some other things, that's not a real hard question. So that's a great way to frame it.
If you're in the ballpark in health policy, that's pretty good.
Well, hopefully that's not the only thing we strive for, but I think you're right. Well, thank you so much for the paper and the insight that it provides for walking through these various hopes and dreams people have, some realistic, some maybe not so realistic, about what it would mean to provide coverage. Dr. Ippolito, thank you for being my guest today on Health Podyssey.
Thanks so much for having me.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about the Health Podyssey.